at the University College London. So, Professor Kevin Urama, you're very welcome, and please proceed with your presentation. Thank you.
Okay, thank you very much for this opportunity to speak to this very important topic, building resilient health systems, lessons from COVID-19. Now, I have to start with a confession. I am not a health expert, so I am more from the policy side. So I'm not going to be digging into the things that the health experts on the panel are going to be touching on. So I'll spend about 8 minutes to run through what in our this is not going through. Okay, let me just put, the slides seem to have gotten stuck. So I'll just try to talk around what exactly do we consider as inclusive health systems, because if we know how we frame the policies, then we'll be able to try to address them effectively. So we're thinking about a resilient health system, a system that has 3 characteristics. One is absorptive. So basically it can absorb the shocks that comes to it. It's adaptive. When the shocks happen, they are able to adapt in order to be able to move forward. And then transformative in the sense that it can transform itself to the new normal, just like in COVID-19, we're having new ways of delivering health system. And this, an inclusive health systems policy or a resilient health systems policy will necessarily have to have these 3 key characteristics. So it has to be shaped by the human experience, not just a consumptive health system that focuses on building hospitals or even training doctors and nurses and delivery of drugs, but actually a health system that starts from preparing people in terms of their socioeconomic, their psychological and environmental systems, how we build our cities, how we build our houses, the water systems, the energy systems, and all those systems targeting to actually give a good human experience that will allow us to have good health. So that is what we have termed inclusive health and wellness for Africa generally. So we think about the food we eat from pregnancy to death, and everything that we do, all that complex interaction of the human experience will become, it is part of the health system that we need to think about. So it's not just about the absence of sickness or disease, but actually preparing the human being to be able to be absorptive, to be adaptive, and also to be transformative when hit by an external shock, be it a virus, a pathogen, or anything that causes illness. And that way, if we did that, we'll be able to provide quality health care for the population and actually reduce health spending by governments, by the private and public sector, and also by individuals significantly. This is just framing the idea around what we wanted to talk about. So from what I have said, you find that a resilient health system must be integrated. So it's not something for the health ministry only. It's actually has to talk about health and wellness, detection and interpretation of diseases and local warning systems, quickly mobilizing itself internally to absorb those shocks, isolate the threats, and also transform itself to adapt to the shocks. And then organically innovate in a way that it can continue to operate in the new normal. Like we have COVID-19, and the shock we had was a lot of the health systems globally was more on the consumptive end. So the ability to adapt to the new shock, the virus, this tiny virus that came into our system was difficult, and we saw most of our systems collapsing. So this is what we bear in mind when we're trying to help with policies for health system. So from what I have said already, it's about food system. Water and sanitation is huge. Education system in terms of how we relate with our environment, relate with our health, and so on and so forth. The social environment, disease control, of course, is there, and the physical environment and infrastructure, including how we build our cities. Last month, I was on a panel in Cambridge University where actually they're now trying to, the health sector departments, the medicine and so on, are trying to now shape the new health policies and the education systems to try and adapt this kind of inclusive health system aspects. And there we were talking with city planners around the world on how to plan cities to provide a healthy population. So we need to think about that, because for us, one of the scares that I personally had about COVID-19, thank God it hasn't come true, is the slums that we have in near our cities. And when we're talking about social distancing and all the public policies that were being prescribed to solve this problem, it wasn't really going to be possible because even people don't come out with a 10 in one room. There's no social distancing happening. So we need to think about all those things. But when we look at our health system where it has been, and when I'm talking more Africa level, but the statistics are very similar in Nigeria. So even though I haven't put out the statistics for Nigeria, it's very similar. There has been a lot of progress in the health sector in Africa. It doesn't come to the fore, but we can see that we have reduced premature mortality and we're prolonging life expectancy since the year 2000. And I've given that statistics. There is a marginal improvement, but it's still an improvement. Maternal mortality ratio is also declining, which is very good. And communicable diseases, malaria, measles, and so on, is also substantially declining in terms of their impacts. But when we look at all the other kinds of indicators like death from cardiovascular disease, death from tuberculosis, from diarrhea and other diseases, HIV, AIDS, life expectancy, and death rate, you find that Nigeria is not doing so well with regard to a very common disease that is there, which is malaria. I was surprised to see that Nigeria is also in the red in HIV AIDS, but in most of the other aspects, Nigeria is actually doing well, better than other African states. Not that we are really there, but that we are not as bad as the other ones could be. But we've had so many early warning systems, which any health minister, any finance minister, or head of state should be thinking about. What are the things that exposed us to major challenges on globally? It's about investing in health system, and I'm happy that the first session has talked about it. We're not doing well in this. Both the MDBs and DFIs and national governments are not doing well in this. And African citizens, Nigerian citizens are spending like 60% of their disposable income on out-of-pocket health expenditure. We don't have good and functioning health insurance schemes and so on and so forth. If you look at all those statistics, we need to think about it in very much depth. So investments is an area that we need to talk about. The other one that we need to talk about is retention of capacity within the health sector. We have a lot of brain drain happening in the health sector and so on. And if you look at all the indicators, you'll find that we could do a lot better. I don't see a continent like Africa and also Nigeria, as wealthy as we are, while leaving our health to donors. We find that a lot of the money that is providing water and sanitation is from UNICEF, from UNIDIS, UN that, UN that, and UN that. So we need to think about how to take control of our health and be able to move things forward. I've given some of the statistics on health financing and medical tourism. I'm focusing on these two because they are really crucial. And COVID-19 has shown us very clear examples where even if you are a minister or a head of state and you don't travel, as we see ourselves often traveling to Europe, America, everywhere, even India, to go and do our health, and spend quite a lot of money traveling and trying to get health. Why not build those infrastructures at home? These statistics are not really very palliative to look at, but these are some of the things I hope that we'll be able to, after this conference and continuing, be able to try and address as we go forward. The density of health professionals in Africa is low from every parameter you try to use to measure it. So really kudos to our doctors and nurses and medical practitioners who choose to stay in Africa, because they're really having a lot of burden, and a lot migrate for several reasons that we have seen and are presented here. A lot of statistics also in terms of how much money we're losing in medical tourism and brain drain is really not understandable why Africa is actually training doctors and nurses, and they are all going outside of the continent, while we need them in Africa, we need them in Nigeria, and we don't have them. Nigeria loses over 1.2 billion in medical tourism every year. And even the data in terms of how much of our doctors and nurses we're losing is difficult to track. But when you track it, we're losing quite a lot that we need to do. We have a lot of indigenous knowledge, medicinal plants. Biodiversity in Africa is very huge. Over 25% of biodiversity of pharmaceuticals are coming from plants from Africa and so on. But we don't have a thriving pharmaceutical industry. Again, it goes back to investment. It goes back to public-private partnerships, which I'm going to come back to. This is just the data on pharmaceuticals. A $1.5 trillion industry. Africa is not there. Nigeria doesn't even appear at all. So now we have COVID-19. We're waiting for people to produce vaccines. We're waiting for people to produce drugs. Do we think they're going to send it to us before they take it to their people? No, of course, they will stockpile it for themselves, and we will buy it at a very high rate, and so on and so forth. Now, these are just transmission channels in terms of how this thing impacts on us. The lessons we are learning is not about health only. It's about the finance, it's about the supply shocks that is happening, it's about the price shocks that is happening, it's about impacts on fiscal balances of countries, it's about lack of coordination between ministries and prevailing conditions. And that's why, for me, this kind of parliamentary process you are having, we need to have the finance ministers here. We need to have the water and environment ministers here, the agriculture ministers here, because all these things come together to produce one health. The greatest impact we have seen around the world by COVID-19 is what we call the hunger pandemic. COVID-19 has killed less than how many people hunger is killing, and is exacerbating that as well. I know my time is running, so let me just run through and finalize a few more slides. Our expenditure on health, I have already mentioned it. Nigeria is not there quite a lot. In terms of access to water and sanitation, Nigeria is way below where we should be. And these are, for me, the things that actually should create health systems for Africa. This is a very funny picture, but very touching for me. This child on the left, I think he just had dinner or breakfast. What is COVID-19 to this person? Hunger is the main problem. The other person is drinking from what Unicef has brought for washing hands from COVID-19. But yet another child there is doing, publishing an article on how COVID-19 has been very good for her, because it actually made the families to come to get back together and share love with each other and so on. We cannot solve this problem focusing only on health. That's one key message I want to make. And then we need to think about inclusive health system. What are the key policies we need to think about? Strategic investments in One Health, that's integrated health system that I've talked about. Financing, at least Nigeria, let us honor the Abuja Declaration and invest 15% of GDP in health. Reversing brain drain, create incentives for our health professionals to remain on the continent and all to come back, or use telemedicine and other systems to help moving things forward. The next is investing in health technology. Telemedicine, robotics, we are seeing it already in many places and so on. And a few other policies that are put out there for us to consider. But let me end by saying we need a national conference on health and wellness in Africa. And in Nigeria, we need to develop a Marshall Plan on One Health. How do we actually approach this in a way that everybody sees that health is wealth and not something we leave to the health ministry alone? And with that, we can develop a good inclusive health policy insurance policy for the country. And that will help to move us forward. Because of time, I'll stop here and just say technology is the new normal after COVID-19. Let's try and migrate from pieces of paper, of writings of doctors and so on, to have our health data online and do e-medicine, telemedicine, and so on. That is the future. Thank you.
Thank you very much. You've given us a lot of material well on. There's an echo. You've given us a lot of material to dwell on during the interactive sessions. So just to recap, I was particularly captured by what you said about the absorptive, in terms of resilient systems that need to be absorptive, adaptive, and transformational. I think the absorptive would mean, like in the UK, they were able to have a force of retired health professionals that could be called up at a moment's notice. We don't really have that here. The other thing was adaptive, meaning that the health force would need to be multi-skilled, so that a nurse who is traditionally doing something else can be quickly put on a different duty post to address the needs that arise. And finally, the transformative character of resilient health systems would be learning from what you're observing. So research, emerging, operational research, learning on the fly, learning on the go from the things that you're presented with, so that we know more and we're able to be more accurate in our approach to it. So I really appreciate that. I also appreciate what you said about the One Health approach, the integrated health approach, which is looking at more than just the disease. You're looking at many things. During the lockdown, we saw the impact of being isolated on mental health. We saw the impact of not being able to go out and get a livelihood for your family. We saw the impact on hunger, on domestic violence, on so many things. The inability to go to school, further widening the divide between the haves and the have-not. I mean, there was really a lot to learn from. So I really appreciate your presentation. Thank you very much. Okay, so next, on your agenda, it was saying that we were supposed to be speaking to Dr. Sanjana Bhardwaj. She's unable to join us, but she's ably represented by Dr. Anis from Unicef. And Dr. Anis, you're very welcome. I would read through Dr. Sanjana's profile as you prepare to give us your presentation. So Dr. Sanjana Bhardwaj is currently the Chief of Health and HIV for Unicef Nigeria, where her portfolio covers maternal, newborn, child and adolescent health and HIV programs, including the humanitarian and emergency response. Dr. Bhardwaj has over 27 years of experience in health and the development sector in general, in different capacities involved in various countries, including India, Papua New Guinea, Barbados, Belize, Trinidad and Tobago, Jamaica, South Africa, and the USA and beyond. She served as a faculty member in the Community Medicine and Public Health Department at the University of West Indies, based in Jamaica, working across 17 English-speaking countries in the Caribbean. Has led the Child Survival and Development Portfolio for UNICEF in South Africa as well. Dr. Bhardwaj holds a master's in public health degree in health behavior from the University of Alabama at Birmingham in the USA, and was recently awarded by distinction the fellowship of the Faculty of Public Health in the UK. So Dr. Anis, you're very welcome to start your presentation. I'm sure we'll learn a lot. Thank you.
Okay, great. So Sanjana is on travel, and I'm just representing her, as well as from UNICEF. I have another colleague, Dr. Kolilu. Hopefully he is also in the presentation, in the call as well. Of course, I mean, I see that the presentation we're going to make but basically,
I'm on the call.
this is what an opportunity for us to present how UNICEF is part of the overall Nigerian health system and supporting government in COVID-19 response. Knowing that, COVID came in a time where Nigeria was also celebrating a big public health achievement, that is polio eradication. So interestingly, I was in a meeting which is basically Nigerian Economic Council, which also discuss about polio. And polio, there was a presidential task force for polio. So that actually had some agenda into it. But during that meeting, the COVID information came, and it was immediate conversion of the presidential task force for polio transforming into COVID task force. So we can see that the Nigerian government and the system which was built for polio is immediately transformed for COVID-19, which I see as big achievement. And of course, I mean, here the panelists and also our participant, you all know that Nigeria is certified polio-free. Not many people believe that we will be able to reach there. So there is a lot of optimism and hope that dealing COVID-19 is not a big challenge for Nigeria because it has the ability and experience dealing with other deadly diseases. Some other countries are still struggling, but Nigeria succeeded. So having said that, I just want to share some of the highlights what we have. We just in UNICEF context, we were able to support government. Khalil, are you there with the presentation? So basically, UNICEF is working both on the supply and on the demand side, and you see we have a big network of community mobilizers in the northern state as well as our networks in the south, and premier supply focused organization which we bring vaccines and other supply materials which immediately help this COVID-19 pandemic. So if you see some of the supply areas, like we're able to bring PPEs and hygiene supplies, which are approximately $1 million and 5,600 healthcare workers, and and the facilities were supported. UNICEF procured 995 oxygen concentrators. All of them were distributed except some issues in Borno because of the security reasons. The procurement of the laboratory test kits, almost 500,000, and distributed across the different states. And also we have been collaborating with Gavi, so it's about 3 million offshore supply and 4 million local hygiene supplies which supported this COVID response. We are heavily into the capacity building. The more than 1,000 healthcare providers trained with active support from UNICEF on case management. The community volunteers who were almost like 20,000 on the ground, but 1/4 of them were capacitated to conduct active case search and tracing the cases across the country and particularly in the northern states. And also we provided technical and financial support, training the RRT team members, and also intrastate transport and other support. On the COVID proofing side, we're able to, ensure all the vaccines arrive in the country during COVID, chartering flights, and government and PHCDA were very much into the, ensuring that during the COVID, the regular services, for example, immunization and antenatal care services are not interrupted. On the epidemiology and surveillance side, that we supported the test samples across the hotspot LGS and the procurement of the ICT equipments, call centers, NCDC call centers, and also we have an innovation called eReport, and with all these platform used for COVID-19 and to support the response. Having said all this health specific support, we have other sectoral approach, nutrition, education, water and sanitation and hygiene, and communication for development and child protection. These are the every areas where having the partnership with the government, and we establish our working relations so that during the COVID-19, the regular support and services are not interrupted. So there's some lessons and reflections which is around the health system strengthening that we jointly see with the government, that partnership and coordination is the key, where the polio task force converted to presidential task force for COVID-19. The Nigeria also innovated the emergency operations center, which has been a bit public-private collaborations, and also these partnership and coordination ensure no duplication. We also see that the data and information systems strengthen, and also the COVID-19. Sometimes someone was telling like crisis is an opportunity. So this also allows that the data system used for other areas has been concentrated and focused around COVID, used for other primary healthcare services, and data analytics are used, for example, the ODK platforms and other methods that use for data collection. The infrastructure and supply, which I mentioned a bit, that UNICEF has this ability for emergency supply offshore and in country, that has been leveraged for COVID, and that is a big learning for the government. Service delivery and quality of care, and of course we all know that COVID brought a specific challenge for health workers. So the IPC capacity building, the IPC training, the wash management, and these are the some of the areas where we are able to learn from this COVID-19. And community platforms, we learned that there are several community platforms, the voluntary community mobilizers, these different NGOs, so everybody came together in one platform. And one of the example is that the UN joint response, all the platforms managed by the different UN agency came together and were able to respond to the COVID-19. So, and also one thing to mention, that this also facilitated timely availability and deployment of domestic resources, such as that basic healthcare provision funds, and it ensures its accountability and its release. So this is all together we are able to just thought to share, and over to you for further discussion. Thank you very much.
Thank you very much, Dr. Anis. It really does, it's quite comforting to know that international NGOs such as UNICEF really dug deep to support the country. Just to highlight some of the things that I took away from your presentation is, and tying it to what Professor Kevin Urama told us earlier about the adaptive characteristic of a resilient health system. I mean, it appears almost as if the unfortunate circumstances around Ebola, polio, have kind of positioned Nigeria in such a way that we were able to adapt to what we found with COVID. The quick transformation of the PTF, the EOCs that were already in place. We talked about the data and information systems. We had surveillance systems already for polio. I mean, you know, it was easy to kind of change the function of those things and have them serve a new purpose. In terms of new things that came out of your presentation, I mean, you know, we all saw how the private sector truly stepped up in terms of partnership. And this is something, I think partnership is something that both the MDGs and the SDGs have kind of been pushing. The need for not just private and public, but also different sectors within the public sector to kind of work together to kind of, you know, to achieve more. And we saw that, we're beginning to see that, at least, you know, with the COVID-19 response, the national response. So, I mean, like you said, every crisis is a potential for, you know, good things to happen. If we're looking at the opportunity as a strategic opportunity, then we can learn from it and be better off for it. So thank you very much for your presentation. And I'm sure people have questions that will come up during the interactive session, including myself. Okay, so next we have Dr. Hadiza. Dr. Hadiza, are you here? You can stop sharing the screen so we can see. So Dr. Hadiza.
Yes, I'm here.
Good afternoon. Thank you so much for joining. It's good to have you. And let me start by introducing you. For those that don't know your background, let me read through your background so people can kind of identify with the expertise that you bring. And if you could please kind of switch on your camera so we can also link a face to the name. That would be great. Okay, so Dr. Hadiza Khamofu is a family physician, a public health specialist, a passionate advocate for women and children. She was previously the director of prevention, care, and treatment, strengthening integrated delivery of HIV/AIDS services of Health Policy Project, which is HPP, funded by USAID, which is the U.S. Agency for International Development, and the U.S. Emergency Fund for AIDS Relief, which is PEPFAR. So we are really, really happy to have you, and we would like to learn from the perspective. So go ahead, you have 8 minutes to be presented. Thank you.
Yes, thank you so much. I can just share my screen. Okay. All right. I hope you can see my slide.
Yes.
All right, great. So basically, I'm just going to share my perspective as an implementing partner in Nigeria. FHI 360 has been in Nigeria for close to 30 years, and it's a global organization and has presence in about 70 countries around the globe. So basically, the topic that has been, it's on a discussion is building a resilient health system, lessons from COVID-19. I have the outline here, but I'll go straight to the introduction. Basically, a resilient health system is one that can protect themselves and human lives from public health impacts of disasters, and that are critical to achieving good health outcomes, both before, during, and after a disaster. So it is not the suffering in silence or suffering and smiling, as Fela would put it. It is basically having a community that has robust social networks as well as systems that can support not only a rapid response, but also a full recovery after an adversity, such as the COVID-19 pandemic. So the COVID-19 pandemic and other recent epidemics, as has been discussed earlier by other speakers, has actually been an opportunity for us to learn a lot. but perhaps it's also a reality check for us to be able to see whether our system is actually able to adapt to certain challenges and certain situations that present itself. So the Ebola pandemic was one of the first reality checks we had in recent times. And to be honest, the global community was so shocked and was not so sure how Nigeria was able to overcome that. But we did, we succeeded. And we have done it again by controlling COVID-19 epidemic in Nigeria. To a large extent, we've not had as many cases as was expected and as were projected. And also, we've not had as many mortalities as was estimated. So there are 5 elements of a resilient health system. I have them outlined here: aware, diverse, self-regulating, integrated, and adaptive. I think some of our previous speakers have spoken to some of this, but I'll just highlight a few components of these 5 elements. So an aware system is one that has up-to-date map of human, physical, and information assets that highlight areas of strength and vulnerability. And we are talking about information sharing, ready to use information on platforms that are easily accessible to everyone at all levels, whether you are sitting in your home as an individual, within the community, whether you are operating as a healthcare provider at the primary, secondary, or tertiary levels of care. And then, of course, this information must be so strategic. We are talking about strategic health information systems and surveillance data within a network that can report on both the status of the system and impending health threats in real time, allowing us to predict, certain occurrences. So our National Health Information Management Information System needs to be standardized across all public and private sectors for us to be able to have full information. What we have currently is a situation where most of our management health information system, actually the data that we collect comes from public facilities with limited coverage in private sector facilities. We need to be able to expand the coverage so that we have full information that can help us in decision making. And of course, we really need real-time data incorporating electronic medical records, particularly patient-level data. And this must be incorporated both at the facility as well as community-based services. Many times what we have as data available at the moment are facility-based data and without incorporating a lot of the services that are provided within the community. Information must be available in a user-friendly mobile application, preferably, to basically use of technology to provide information on the go. There are also toll-free lines that are in use at the moment. There is also telemedicine that we must take seriously. I mean, the lockdown with the pandemic has taught us a big lesson that telemedicine must be taken seriously in this country. For diverse, we have a system, we're talking about a system that has the capacity to address a broad range of health challenges, from providing frontline primary health care services to specialized care. And all these service and referral networks must be the information on this service directory and referral networks must be readily available to individuals within the community. We need a well-coordinated system that is stable and capable of detecting disturbances when they arise. We need efficient supply chain that addresses diverse health needs. I can tell you that it is when you have a complicated illness that you understand how important this is. Cancer patients, for example, in Nigeria will go through a lot of suffering just trying to find availability. We wish we could have a platform where it is easy to locate where these commodities and drugs are available within our system. We also need a blended financing model that actually secures financing for our health system so that finance is available when it is needed. And also it ensures efficient use of the scarce resources that we have. The system must be self-regulating, have the ability to contain and isolate health threats while delivering core health services, which means we shouldn't have a disruption just simply because we have an epidemic. We should be able to adapt very quickly and to rise up to the occasion and to be able to continue to provide core services while responding to a threat. The availability in particular locations of excess or redundant capacity can also be quickly brought online if we are aware of its location. For example, human resource can be mobilized when the need arises. Commodities can be mobilized when the need arises. Integration is one of the very important approaches that must be adopted at all times and at all levels. This brings together diverse actors, ideas, groups, to formulate solutions and to initiate action. Basically, we are looking at a multi-sectoral response, and this is precisely what has been used in the Ebola response as well as in the COVID-19 response, and in many, many other communicable diseases that we have faced in this country. Then, of course, this helps with sharing of information, clear communication and coordination of the multiple actors, which helps, to have an efficient and effective system that is able to deliver on the needs of the populace. Then, of course, service integration can happen at the level of the clinics, at the level of pharmacies, laboratories, medical records, and so on. Something that is very, very critical going into the future is integration of new vaccines into our routine immunization that incorporates not just children, but also adults who will need COVID-19 vaccination. So we'll need to look at integration in that context. The last one is adaptability, which basically speaks to the ability to transform the system in ways that improve function in the face of highly adverse conditions. So adaptations should enhance both performance in the short term and ideally also contributing to long-term resilience. So to wrap this all up is the importance of operational research. The only reason why we're able to learn very quickly and to be able to adapt very quickly is because we're researching the situation as it presents itself. So with the COVID-19 response, of course, the critical component of the response is operational research. And the more we understand about the disease, the more we're able to respond adequately to it. So we have learned a lot through this. One of this is the fact that, of course, there are individuals who are asymptomatic. Here you can see the first graph in green shows a winning country, a country that has a steep rise but is able to quickly control the epidemic and bring it down to almost baseline. Then we have the second graph shows a country that is nearly there. They are struggling to really bring it down. And then there's the third country in red that needs urgent help. Your guess is as good as mine. Which one is Nigeria here? So we have some countries, country examples here, and you can see the different shapes of the graph. It will tell a specific story. Now you can see Nigeria at the bottom and it's in red. So we will really need to look at that, our ability to respond to epidemics as quickly as possible. Then one of the platforms that we have leveraged upon in Nigeria is the HIV platform. Close to 30 years of investment in HIV has actually built our health system in terms of infrastructure and equipment with the ART clinics, the pharmacies, the laboratories. In many of these facilities, water supply was set up for the first time, or electricity supply, waste management, a lot of capacity building for human resource for health, and of course distribution. We have also done a lot of advocacy that has helped with the distribution of the human resource. Because in Nigeria, what you find is not the complete absence of human resource, but the inequitable distribution of these resources. Then we have, of course, a lot of technical approaches that has evolved with development of SOPs, guidelines, and job aids. Basically, a lot of learnings, within the HIV response. This has been leveraged upon for the COVID-19 response. Basically, most of our laboratories were used for diagnostic, the development of diagnostic platforms that have helped with COVID-19 diagnosis. And of course, a lot of the human resource capacity for control of infectious diseases was also leveraged upon, and so on and so forth. And all the learnings we have had from HIV has to be utilized in this COVID-19 response. So one of the earliest adaptations that we had to do in health facilities particularly was basically categorization of the healthcare. The clients that we actually have within our healthcare based on their conditions. So we have category 1 individuals that basically present regularly on a day-to-day basis to the health facility with malaria and the common illnesses. Then we also have category 2 individuals who are on a routine schedule, like antenatal care, non-communicable diseases like hypertension and diabetes, and category 3, which are like severe and also emergency situations that need to be attended to. Now, in order to be able to manage effectively the flow of clients within facilities, we had to do this level of categorization in order to reduce exposure and risks to individuals that have to come in contact with facilities. And of course, this requires strict management of appointments and so on and so forth. Other interventions will be shared with you. We also have adaptations in service delivery to COVID-19 in the context of Nigeria as well as other countries where a lot of things were done virtually using online platforms, including telemedicine and use of telephone calls and so on and so forth. One of the adaptations is also what is called multi-month prescribing and multi-month dispensing of antiretroviral drugs, where we were able to actually give clients drugs for as long as 3 months, for some as long as 6 months, in order to reduce their contact with health facilities and to reduce their exposure to COVID-19. One of the areas where we have had a lot of anxiety is in the Northeast, where we have individuals that have been displaced from their communities and are living in IDP camps. In that context, of course, you can imagine that the living conditions are less than is desirable. And of course, we've had to handle a lot of outbreaks within this humanitarian crisis. Outbreaks such as cholera in 2017, as well as in 2018 in Dikwa and Gala in Borno State, hepatitis E outbreak in 2017 in Ngala community. This has taught us a lot of lessons in terms of making sure that there's effective coordination with clear leadership. And then it has also, of course, built a lot of skills and commitment in the workforce to rise to the occasion when there is an epidemic. And of course, having a clear plan, a clear contingency plan, basically mobilizing all the human resource that you can, both skilled as well as other lay individuals through task shifting and task sharing. Of course, daily review meetings and daily updates in situation rooms, and of course, a lot of flexibility as information is provided. So, in conclusion, I believe that the challenges of Ebola and COVID-19 have taught us critical lessons and provided opportunity for building our health system towards a better and a more resilient health system. So I would like to stop there here in the interest of time, and thank you very much.
Thank you very much. For those of you just joining, that was Dr. Hadiza Khamofu, who is the country director of FHI 360, right here in Abuja. So yes, thank you very much, Ma, for your contribution. I really appreciate the hands-on experience that you bring to this forum. When you talked about, the over-dependence on facility data as opposed to community-based data, we found that COVID-19 is not just about the disease itself. I think just a small portion of it is really about the disease itself, particularly in Nigeria here. It's more about the indirect effects that it has on the community, and it's important that we gather that information and use it to make decisions about how we service, we provide healthcare. So thank you very much for that. Next, we have John Adedoyin. Dr. John. Mr. John, are you with us? Are you connected? And can we see your face?
Okay.
Thank you very much.
Yeah.
So as you're doing that, Mr. John Adedayo is the Director of Monitoring, Evaluation and Learning, Health Information Systems for Resilient and Sustainable Systems for Health in MSH, which is Management Sciences for Health, Nigeria. He holds a master's degree in epidemiology and community health. He's an expert in strategic health information, data management, and health system strengthening to drive sustainable positive change. He has more than 12 years of progressive senior management experience managing large and complex USAID projects aimed at strengthening health systems such as supply chain, health information management systems, service delivery for HIV and AIDS, family planning, maternal and child health, TB, and malaria. So you're very welcome, sir, and we look forward to hearing your presentation. You have 8 minutes. Go ahead.
Thank you so much, and it's a pleasure to be on this panel. I think I have the real privilege of speaking after other people who have spoken. So my own will not be as elaborate as the others have on the two videos. Start sharing my slides. Really, the first one, I'll do a few definitions and to have resilience that we have place in the message. So the next slide, please. Let's move to the next slide. Slide number 4. Okay, so I won't repeat what every other person has said, but I would just want to add 2 things that the resilient system needs to have adequate and disciplined human resources, and which is guided by a strategic framework, and all stakeholders in health work to implement it, and all indeed is coordinated. And it's a system that works in normal situation, in an emergency, and also during disease outbreak. So let's go on to the next term. We've also talked about universal health coverage, which is also talking about access to health, but in such a way that everybody is able to get exactly what they need, of good quality, and they do not have to pay too much to get it. which is actually what is needed in a resilient system. Let's move on to the next term. That's number 6. The system also needs to be sustainable, because it's of no use having good health system for 6 months and thereafter you are not able to do that. And in order to have a sustainable system, there must be ownership and availability of local funding. Just like Prof mentioned, the majority of our systems here rely on funding from donors and so on and so forth. Service providers must have the capacity to provide the services required. And again, I go back to strategic plan, which will guide activities. And like Prof and Dr. Khamofu said, data is important to guide activities. So let me go on to the real issues at stake now. The next slide, please. So why we need a resilient system? I won't spend so much time here again, because Prof already dealt with this extensively. But in a situation in Nigeria, the population is huge, 187, 189 million, and the disease burdens are actually high, especially for malaria, HIV, diarrhea diseases, and all of these are really preventable. And if you look at the proxy indicators for health coverage, they are also not so good. And also, when you consider our health systems, it is weak. It is fragmented in the sense that health is on the concurrent list at the local government level. So most of the time, things fall through, they could be useful. There is no guarantee that the other levels will be. And I will talk about that, about innovations, because the Ministry of Health and also the health finance in Nigeria is a little bit inadequate based on all what we've seen. The out-of-pocket expenditure is what I want to highlight on the other side. It's about 76.6%, which is why it is. So these are some of the let's go to the next slide to talk about. Let's have the next slide, please. Anyway, before the next slide comes up, during data we have between March and June 2020, there is a sharp decline in all hospital or facility utilization, the clients and the people. You can see
Okay, so I think in the interest of time, Mr. John Adedoyin, if you're able to, if your network improves, you can indicate, you can let us know through the chat so that we can give you the chance to finish your last slide before you conclude. Thank you very much. My only immediate feedback to the presentation is just that we had hoped that the information that will be shared would be solution oriented, as opposed to the issue. We all know the issues that Nigeria already has. And we know that COVID-19 has sort of worsened the parameters that we use to benchmark our performance in the health system. But I would say that I'm sure during the interactive session, we'll have a chance to understand exactly how COVID-19 has affected the indicators that were shown to us on this previous slide and other slides that other people may be interested in. So, Mr. John, please stand by. Don't stand back, but just stand by. The idea is that people will still have a chance to ask you questions, particularly around monitoring and evaluation for the COVID-19 national and subnational response so far. Thank you very much.
Sorry.
Okay, so we now have another, our DG. Are you back? Okay. Dr. John, you want to go ahead? Your network is, okay, we've lost them altogether. Okay, so we'll proceed with the next presentation. The DG NCDC was supposed to join us at 3 o'clock, and true to that agreement, he's here on the panel. We're glad to have you, Dr. Chikwe. And I will just read through. I know I don't think there's anybody in Nigeria who doesn't know who he is, given how frequently he's been on TV. But I will read his bio just so that people can get a sense of his background. So, Dr. Chikwe Ihekweazu is the Director General of the Nigeria Center for Disease Control and was, until January 2018, the Acting Director of the Regional Center for Disease Control for West Africa. He trained as an infectious disease epidemiologist and has over 20 years experience working in senior public health and leadership positions in several national public health institutes, including the South African National Institute for Communicable Diseases, the UK's Health Protection Agency, and Germany's Robert Koch Institute. He has led several short-term engagements with WHO, mainly in response to major infectious disease outbreaks around the world, including the WHO China Joint Mission on Coronavirus Disease 2019 in February 2020. So, sir, we're really glad to have you on our forum, and we can't wait to hear what you have to tell us about the lessons that have been learned from COVID-19 since you've been at the helm of affairs. So go ahead.
Thank you very much, Dr. Anea. Thank you for all those that have joined and online. I thought to keep today's session a little bit reflective so that, like you said, we can go into thinking forward into what the solutions are moving forward. Well, it's been a unique year for our country, like you can all imagine, and we have to really challenge ourselves in terms of thinking how we can rearrange many of the things that are important to us. So I'll try and share my screen now. Can you see it?
Yes.
Okay. And then I'll try and maximize it. Yeah. Okay, great. So I haven't put too many slides because I really thought this is an opportunity to think with our esteemed audience and look at how we can stimulate some thoughts about what the future will look like. But firstly, of course, just to set the scene, from just under 700,000 tests, we now have confirmed about 65,000 people, cases. We've had just over 1,100 deaths. We report still anything between 100 to 200 cases every day. So this disease has definitely not gone away. It's unlikely to do so until we have a definitive tool to deal with it. So it's something that we will have to continue learning how to adapt to. We have worked extremely hard, and we must have a certain amount of pride as a country on our response. So far, it's come at a collective cost, both to the economy, to our way of life, to the way we interact with each other. And even up to today, it still has an impact on many things we took for granted. International travel is no longer straightforward. And we have just over the last few months started reopening fairly successfully certain parts of the economy. We started with businesses, gradually in a very calibrated way, went to offices and government institutions using a graduated approach in terms of your salary grade, just to make sure that we don't pack the offices full at the beginning. Then went to the airlines, the aviation industry, and then schools. And just this week, we're working with NYSC across the country, 36 plus 1 states, to reopen safely NYSC camps, having worked very closely together with NYSC over the past few months to come up with a way to do this safely. So even when you don't hear a lot, we're always working quietly with institutions to, on the one hand, mitigate the impact of the outbreak in terms of the transmission of the virus itself, but also to support institutions and the rest of society in opening up. A lot of what we have done, deployed for this outbreak, is really because of the lessons that we have learned from previous ones. And this is not a history that we are proud of, but this is our reality. Because of the population density in Nigeria, climatic conditions being in the middle of the tropics, our socioeconomic realities, we will continue to face the threat of emerging and re-emerging infections. And these are just the big ones that we have dealt with, from Ebola in 2014, the re-emergence of polio in 2016, which we have just finally managed to drive our work to elimination of wild polio virus. In between this outbreak this year, we announced that very significant milestone. In 2017, some of you will remember a very big outbreak of meningitis in the northwestern states predominantly. It really shook us as a nation. We saw the re-emergence of monkeypox. Yellow fever is not even on this graph. And we've had every year increasing numbers of Lassa fever detected. Yes, these have been our challenges, but it is through the response to these outbreaks that we have built a public health workforce that has enabled us do all the other work that we've done during this outbreak. How have we done this? You know, a few years ago, we set up the Nigeria Center for Disease Control, where this is a fairly young parastatal, the youngest parastatal in the health sector and one of the youngest in the country. We are organized on 3 campuses. You can see the images on the right. Our headquarters from in Jabi, where I'm speaking from, our national reference lab, an institution that we must all be very proud of, and where it all started at the Central Public Health Lab in Lagos. Our mandate is to prevent, detect, and control the spread of communicable diseases, to coordinate surveillance systems, to collect, analyze, and interpret data, support states. So everyone should remember we're in a federal republic. The primary responsibility around public health, health protection, delivery of health services at the state level. So our mandate is to support the states in responding to small outbreaks, and to support a network of public health labs across the country. We've been doing this increasingly as the number of labs have increased. We are also responsible for collecting, synthesizing public health research to inform policy and to coordinate our responsibility with the international community around the international health regulations. Now, how have we been doing this? One challenge that we've had with this outbreak and an opportunity is scale. You know, previously we have responded to relatively not small, but localized outbreaks in a few states in Nigeria. Never has there been a time where we from NCDC have had to support the 36+1 states in Nigeria concurrently in the response to an outbreak. So once you deal with scale, you can no longer do this with your Excel sheets and your manual counting of whatever you have to count. So we started already on this journey, but we have now rapidly expanded our use of information technology. So SOMAS, of which there's a picture here, is our surveillance system through which we collect information, analyze information in real time. This is what enables us to announce new cases to Nigerians every single night. We haven't missed a single night since February of this year. The very few public sector, even private sector organizations that can say that they release their data on a daily basis to Nigerians around what is happening. This is made possible because we have a robust surveillance software called SOMAS. But we've also had to develop software for other aspects of our work. We've had to develop a logistics management tool because, you know, when you're deploying PPEs, lab commodities across Nigeria, everyone that has donated one mask to you wants extensive accountability of whatever they have donated, rightly so. So you cannot do this without having a system to do this. So right now, I can proudly say that whatever you have donated, whatever the private sector has donated, we can say exactly what has come in and exactly what has gone out and to where. So this is only possible with the deployment of information technology systems. So these are just two examples I wanted to show around the whole IT space. The other area is really a multifaceted response required to do this. We all have to remember that COVID, or the SARS-CoV-2, that the virus that causes the disease called COVID, is primarily a zoonotic disease. Even though most of transmission now happens from humans to humans, this is a virus that emerged from an animal source initially. Therefore, we call it a zoonotic disease. And many of the diseases we deal with as zoonotic diseases, Lassa fever, monkeypox, they all come from animal hosts. So when you're dealing with mostly viruses that come from animals, you cannot deal with this only from a health side. You have to really work closely together with our colleagues in animal health, in the environment, and develop what we call a One Health approach. And this is sometimes easier said than done. But you know, it's something we have to keep remembering as we come emerging and re-emerging viruses, not just the COVID, and the various aspects of influences transmission of infectious diseases. And critically for humans, the elephant in the room for Nigeria is the second point of the circle on humans, is our population growth. This will have a big impact on infectious diseases, but it will also have a big impact on healthcare services, on education, of all the other things that lead to, therefore, an increase in infectious disease. For infectious disease, it's a very simple to recognize. Even if you don't, we're not very interested in maths in your school time, you will recognize that the more people living in a defined space, because we cannot increase our space. So the more people are living in a defined space, the easier it is for a virus to jump from one to the other. And our population is growing at an annual rate of 3%, just under 3% estimated per annum. It means that with every single year, the risk of transmission of infectious disease from one human to the other, living in the confined space we call Nigeria, is increasing. So if every other thing stays constant, our risk of infectious diseases will increase just because the population is increasing. The next thing that this outbreak has really taught us is that there are many things we need to control infectious diseases that we cannot do as just the public health institute. We have to work across government. We have to work with education sector, environment sector, the security services. And that's kind of how this response has been driven. Through a well-coordinated presidential task force led by the Secretary to the Government of the Federation with the authority and the mandate of the President to take action as necessary. Our role has been really to lead the public health response, but the public health response is enabled by finance, is enabled by action in the environment and many other activities across government. So what we have done is really develop these relationships a lot more quicker and deeper over the past few weeks, and really work together in order to get Nigeria to where we are at the moment. So to conclude with a simple question, what is at stake? And it's something we have to think about. When last have we shut down our entire economy in Nigeria? Closed international travel, stopped banking, stopped education, stopped everything. I can't remember any time in my lifetime. And this has been caused by the emergence of one virus. We can go to bed thinking that this is a once in a generation event, but it is not true. The risks of infectious disease are increasing. We will be faced with the emergence of more infectious diseases. Travel across the world has increased more than ever before. So the emergence of a virus in China can so easily spread, as has been demonstrated this year, to becoming a global pandemic. So this is no longer a hypothetical risk. This is a clear and present danger to Nigeria and Nigerians, and we have to completely rethink how we conceptualize and how we understand the risks of emerging infectious disease, and put in the resources, both human, infrastructural, and financial, into building a health security architecture that will support our country into the future. This is the case I am making to the country, to our leaders, and to Nigerians right now, that we must learn the right lessons from this outbreak, not go back and thank God for saving us, but really make the right investments now that will protect us into the future. Thank you very much. In conclusion, Nigeria's entire response has been really leveraged on what we have been learning from previous outbreaks. We do need not just investment from population, from our own government, from the private sector, but support from Nigerians, understanding that despite all the other challenges we face day to day, whether it's security, infrastructure, light, water, this is a clear and present danger to our existence. And we do need a robust and resilient health sector to protect the country, especially health security architecture from future outbreaks. So thank you very much. Happy to stay for a while and answer any questions you might have and contribute to the conversation that we will have. Thank you.
Thank you very, very much. I mean, that answered a lot of questions that I had. I'm sure the participants also must have really gleaned a lot from what you said. I think the two things that really stuck out for me was when you talked about scale. The scale of this is massive in terms of what needs to be done. So it's one thing to have the framework, it's another thing to have the resources to address it as the framework says to do. And then the other thing was, when you talked about just the level of interaction, the level of intersectoral or multi-sectoral working has gone on as a result of the just using the pandemic as a reason to gather, has shown what we're capable of doing. In the interest, I know that this was supposed to be, we're supposed to have an interactive session where members of where participants are allowed to ask their own questions. I'm also supposed to be like the first partaker that's right to ask the question. In the interest of time, though, I will ask only 2 questions, and I ask the other panelists to please bear with me. It's not every time that we get to the Ihekweazu right here to ask questions. So the 2 questions that I have are for him and for NCDC. The first one is around testing. So with the numbers that you flashed in your presentation, we have just under 700,000 samples tested. In a population of 206 million people, that translates to about 1/3 of a percent, right? So given that many of us are not allowed, Nigerians in general are not allowed to travel now because we're on this list of banned countries. And secondly, we don't know the extent to which this is, people are not availing themselves for testing, or whether the testing facilities are not adequate given the scale of what we are dealing with. We don't really understand the bottleneck, so we would love to hear your perspective on the plans to ramp up testing for us to have a credible set of numbers that the world can look at and say that this is the true picture of what's happening in the country, rather than them saying that they can't look at our numbers because we are obviously under testing. Thank you.
So thanks for that. That's a really important question for many people. I think firstly is to say, yes, we started from a very low base in terms of our testing capacity. And we've worked very aggressively. And the story of that journey will be told at some point in terms of how we have built up our molecular laboratory diagnostic infrastructure across the country so rapidly in a few months. So there are great parts to this. We're testing currently about 3,000 to 4,000 people a day. We have a capacity to test about 15,000 every day to 20 if we push. So the problem right now is not the capacity to test. The problem really is that we've reached kind of a bit of apathy in our population, and therefore people are not coming out as much as we would like them to. But also remember, if we measure everything over our 200 million population, it always seems like we're doing very badly. To be honest, we're doing very well in the states that have had significant outbreaks. So we set a baseline of testing 1% of your entire population. We haven't reached that by any means for Nigeria, but we have far exceeded that in Lagos, exceeded that in FCT, gotten to it in Rivers, Plateau, Gombe. So there are states that have done very well. And Lagos has really been an example in this regard, but it's also linked to the fact that they've had the most cases. So people have seen neighbors die. They've seen loved ones become very ill. And when you've seen that happen in your neighborhood, you're more likely to test than in a state that really hasn't had a significant number of cases, and we thank God that they haven't. So really, there's a little bit more in the detail to that. But we are pushing. This week, we are working with NYSC to reopen the camps, and we are testing every single person. The 440,000 people that are starting the NYSC this week are being tested as they come into camp. So we're using every opportunity where people congregate in ways that are unavoidable. So we just had to start NYSC. We couldn't say postpone it forever. So in order to do that, we said, okay, we'll reach a compromise, we'll test everyone so we know that once you're going into camp, you're free from the virus. And so through that, for instance, we'll increase our testing. They're just doing stream 1. They have 2 more streams into next year. So whatever opportunity we have now to scale testing, we're beginning to do that. We've just approved the use of an antigen rapid diagnostic test kit that we're trialing out. So there'll be many opportunities. But the key thing really is for Nigerians to remember, this hasn't gone away. Now there's testing closer to everyone. And don't be afraid. There's a lot of anxiety around what will happen, but we've really improved the system a lot, allowed home care in certain circumstances. So I hope through this webinar, for instance, that we'll find a few more people coming forward to test as well.
Yeah. Okay, so thank you very much. I haven't done my own testing, but I need to give myself a testing. Okay, I have one more question for you, and then we'll quickly move to the full interactive section. We've seen the excellent coordination at national level. I mean, we've watched it day after day. The PTF is on their game. You are, at NCDC, you're very clear on what needs to happen. You have the numbers at your fingertips. However, at this point in the game, the key players are really the state governments. So, and we've all seen, you know, the NSAS protest showed how the palliatives that were sent to state level were hidden in warehouses. You know, a lot of people in the States don't even believe that COVID exists because they have not received messaging. Nobody has given them, you know, any information about where they can get tested and things like that. And the excuse that keeps emerging from state level is the lack of funds. So without funds, that they do not see how they can carry out all the things that are necessary to do. Now the money has come. What is the methodology or the framework for ensuring that at subnational levels, that the guidelines that have been set for the response as we should have it? And unfortunately, there's a disconnect between the availability of the finance and the need for the action in the first place. I mean, when the pandemic was fresh, that would have been the time to get people's attention and get them to comply with whatever the guidelines were. Now time has elapsed, and now it's going to be more difficult for states, state indigents to comply with what the state governors are asking them to do. So how does the NCDC expect to, by proxy, kind of control the quality of the response at subnational level, given that you can't be everywhere? Thank you.
Yeah, no, thanks. That's a very challenging question. The first thing to say is, you know, we chose a style of government that is a federal republic. So we have to accept the pros and the cons. You know, the pros are obviously that it's much more closer to the people, and the governance should happen much closer to the people generally. The cons are that one of them, at least, is when you have a national response, it's very difficult to get the authority required for action at the state level. Outside of the armed forces and the police and things like that, that have a central command and control architecture, every other thing, the states really lead on enforcement at the state level. Having said that, really, we came up with a mechanism between the Presidential Task Force and the National Economic Council to have a subgroup of PTF and a subgroup of NEC that meets every other week to make sure that we align on policies at the national and state levels. In fact, we had a meeting last night. It's led on by His Excellency, the Governor of Delta State, Senator Okowa. He takes that task very seriously, and we always meet to align on policies and actions. If you look across the landscape of states in Nigeria, you will find that most states have actually aligned with federal government policies, probably apart from one state that I will not mention here. Every other state has really carried on and aligned with what we have been trying to do, and done it very well. You know, I think the unfortunate incidents around the warehousing, the warehouses that were looted during the demonstrations, I am not the police, I don't know the details, but I do think if I were to explain what happened, it is probably more as a result of inefficiency in distribution mechanisms than anyone actually trying to hide commodities, because most of these were procured by the private sector. But and you know, it takes a while for everything to be there, for them to approve distribution. And then, you know, if you tell me now, how to distribute things, even to staff of NCDC, is difficult enough, not to talk about distributing food commodities in states. So I think there are many important questions that these demonstrations have brought to fore. And after the exuberant demonstrations, we must sit back down and look at the questions, the real questions of access, of mechanisms, whether you want to do cash transfers or whether you want to give out food stuff. You have to have a mechanism to do so. So there are things that we need to start building up on. And if I refer to one of my slides, just in the distribution of PPEs, to be honest, this is something that we would have also failed on completely. If last year something happened and we got some help to set up this IT platform that we didn't know we would need to the extent, because we had 2 rooms full of PPEs that we were using. Suddenly you have a full warehouse of things that you had to distribute every 2 weeks. We were sending out trucks to all the states in the country. So if you're not prepared for something like this and you have a big bang event, it becomes very difficult to manage the logistics around it. So, but back to your primary question, I think there are a lot of lessons learned and we continue to learn them. And there are lots of questions, and it's important that we're asking it. How do we work across the different layers of government in Nigeria around public health, around policing is always on the agenda, around education. And if we don't really rethink how to do this more efficiently, we'll keep hitting stumbling blocks through our national life.
Thank you so much for those responses. I will now hand over to Dr. Chioma Nwakanma, who will be taking the interactive session, taking entertaining questions being fielded by our participants. Chioma, go ahead.
All right, thank you so much, Dr. Nkem. That was a very enlightening session. Thank you also to all our panelists. It was really very insightful. And I want to say thank you for the, thank you to the participants who have been here, with us since morning. After the morning session, we had a quick break and a lot of you are still back here. So thank you. I hope and I believe it's been very enlightening. And I've been seeing a lot of questions. I think I love the quality of questions. It shows that we have been paying attention. Thank you so much for that presentation.
Okay, sorry. I said before we go into the interactive session fully, I just wanted to address a quick question to the DG of NCDC, Dr. Chike Ihekweazu. Secondly, I also want to use the opportunity to actually express gratitude, and thank you for the good work that NCDC has been doing. NCDC, you are actually, and I don't say this because you're here, you're actually the star of this government this year. The way the response has been so coordinated, it is something that leaves us with hope, especially as young people. And I must say that indeed, there are a lot of lessons to be learned for the entire health sector from how the NCDC has approached the pandemic. And that actually leads me to the very important question I want to ask. I mean, one of the 6 building blocks, even as mentioned by Dr. Hadiza, who's joining us from FHI 360, is health management information systems, national health management information systems. And so my question to you, sir, is NCDC has made quite some advancements when it comes to information systems based on their reaction to the COVID pandemic. And I'd like to know, sir, what lessons, or how do you think, or what recommendations would you make to the entire Ministry of Health, the other governmental agencies and departments in this sector? What recommendations will you make to them in terms of taking a cue from how you've handled information systems? And additionally, this panel is serving as a feedback to the National Assembly, especially the committees on health institutions and health services. How would you request for their support, especially for NCDC and for the entire health sector? What support would you request from these committees in terms of advancing things like the information system for the entire sector and otherwise? Thank you.
Okay, so thanks a lot. And firstly, thanks for your kind words, but also to say that there have been many other key people that have been involved in the delivery of the response. So it's really been a really collaborative effort, and credit to everyone. But also to say we're not out of it yet. There's a significant pandemic going on still. So we must keep working hard across board to sustain the gains that we've made. I think in terms of your first question, in terms of advice to the others, I think firstly, I think the health sector right now and the parastatals are really blessed with leadership that is very proactive, and everyone is thinking about how to develop their parastatals, whether it's my brother at MPACDA, Dr. Schreib, or NHIS. Everyone is really focused on how to improve the work that we're doing. But I think one thing we've all learned collectively is to deliver on a mandate, you have to build the institution. You have to build the people, you have to build the systems that you will need to deliver. And very often, we haven't done enough of that. And we have relied on partners to do most of our work for us. We've depended on funding from outside to drive the work. Therefore, the accountability for the work that we've done hasn't been to our own leadership, because action follows the money generally. So there are big issues around our work. But I think generally the health sector institutions are really focused on improving and soliciting for more support from the rest of the economy and government. We live in a very challenging context. You know, I wouldn't want to be in Mr. President's shoes by any means, because there's such a scramble for resources, very legitimate in a way, because, you know, our problems are so huge and the expectations of Nigerians are just as big. But somehow we have to make sure that health, and particularly health security, falls into that equation. The second question around the message for our colleagues in the National Assembly really is, we need a step change for health security, and that's kind of the last point in my presentation. If we continue business as usual, then we will end up inevitably with a situation where the next outbreak we'll have to shut down the economy again. But if we do those things we need to do now, then in a year's time or 2 years' time, when we face a similar threat, we can say to government, listen, we have the tools and the people to mitigate the impact of this without having to use a blunt instrument such as shutting down everything. Shutting down the entire economy has to be a last resort and not your first resort. But we had to do that because we didn't have the tools. We didn't have the laboratory architecture. We didn't have all the things we needed. So we appeal to Mr. President to buy us some time to shut down the country. I still think it was the right decision for some time in order for us to then prepare our response. But we don't want to have to be in a position to do that again. And that will require some courageous investments now to prepare us for the future that we want to build. Over.
Okay, Obina.
Thank you very much. Obina, can I go on? Okay. Okay, thank you so much for that one, Dr. Chikwe. I think my take home from this whole session, especially yours, is that, you know, we have to rethink how we conceptualize infectious diseases. There's something you said that was really striking to me, and I think it should resonate with everybody here. You know, when you were talking about the last slide where you said, what is at stake? And are we ready for the next pandemic? You know, you said, even though, yeah, things have reached.
I think we've lost her.
Chioma, can you hear us? No.
From the audience, you know, directed to you, and I'm just going to sift through some of them.
Okay, Chioma, we keep losing and getting you back. So,
okay.
can you hear us now?
All right. While we wait for her to join us, I'll just go through a few of the questions.
Okay.
Chioma, are you with us?
Yeah, I'm with you. Sorry about that. I had no idea.
All right, please go.
Okay. Okay. Thank you. Thank you. So I was just going to go through some of the questions that we have from the audience. And I was saying that I'm going to sift through some of them so that I don't ask a question that has already been addressed. So you mentioned, sir, this is for Dr. Chikwe. Sir, you mentioned that in your presentation, you talked about the journey so far, you know, from 2014 to this point. And there's a question here. Someone asked, what was done differently to contain the Ebola outbreak that hasn't been done during the present pandemic? You know, so I don't know if you would like to weigh in on that.
Yeah, thanks, Chioma. Thanks for the good work you do as well. I think the Ebola outbreak was by definition a different type of virus. You know, you needed to have physical contact and exchange of body fluids in order for that virus to go from one individual to another. And therefore, people most at risk were people, either family members that were caring for the ill, healthcare workers, and it spread in that nature. And if you could interrupt transmission by interrupting people in that close proximity, then you have a much stronger, better opportunity of interrupting the outbreak. And that was the strategy that was used for the Ebola outbreak. With COVID, it's different. Like, you know, it's a respiratory virus that can be transmitted primarily by droplets, but also by some airborne transmission in some cases. So the dynamics of transmission are very much different and therefore make people a lot more vulnerable. You know, for a virus to be best adapted to human populations, it has to have a balance of characteristics. The Ebola virus almost has a feature that limits its own ability to be sustained in populations. It kills people so quickly that once you have an outbreak, yes, it has a high case fatality ratio, but it kills as many people too quickly for it to be able to be sustained. And so you can see that even in contexts where it has sustained large outbreaks, they're really in crisis areas in the DRC and the rest of them, you know. So I'm confident that, you know, if there were to be an Ebola virus, it would be a lot easier to contain in a place like Nigeria. So the SARS-CoV-2, the virus that causes COVID-19, is very well adapted because of this feature of asymptomatics. So people that have the virus can transmit it, but are themselves not ill. And so when a virus is so well adapted to human populations, it's really a very difficult challenge to face, like we've all seen. And the level of diligence that it requires in our implementing the so-called non-pharmaceutical interventions makes it really easy to drop the ball. And we're seeing that in terms of the situation in countries that we have looked up to for many years, really struggling with the control of this virus because it comes into conflict with personal liberty, something that is held very dear in many of the Western countries in the world.
Thank you so much for that one. I think I'll just ask one more question before I move to the next panelist for now. So I know one of the challenges that we had at the beginning of this pandemic was what I like to call the fake news pandemic. You know, so we had a lot of people coming up with different theories, I mean, conspiracy theories. And, you know, that has really led to a lot of apathy, which you've also testified to, especially as regards testing, you know, currently. And there's a question I have here that I think is addressing that. So this question is saying, what can you say is the reason Nigeria has a much lower than expected mortality, as compared to other countries which are relatively more developed and have stronger health systems than Nigeria? I mean, we are more populated. There was this fear at the beginning that once it comes, it's going to wipe us out, So what do you think, was the reason, or is the reason why we're witnessing, lower mortality rates in Nigeria?
So I'll give you an honest answer that many scientists don't like giving, right? That we don't know enough about this virus yet to be completely open with what has led to this. There are many theories out there. All of them may have some validity, but we cannot know until we have studied this virus, the population, and the environment in sufficient detail for us to then even make the conclusion on mortality. Remember, mortality, the term we use, the case fatality ratio, the proportion of deaths among all cases, is defined by two things: death and infection. Now, deaths are very easy to measure because if you're dead, we know. But infection is harder. So especially with this virus where there are a lot of asymptomatic infections. So we know that we're not detecting all the cases that we have, but we're also fairly confident that we're not missing too many, because if we were missing too many, our hospitals will be overwhelmed with cases. There are lots of other indicators. We measure cases in healthcare workers. We've also seen that decline. So there's a triangulation of our data that supports the trends, but I'm not saying that we're not missing a few cases here and there. But to answer your question, the truth is we don't know, and we will keep studying this in order to find out more over time.
All right, then final one. So people want to know, I mean, there's been a lot of talk on social media and I mean, in the health news world about vaccines, coming up. So we'd like to know, firstly, is there an approved vaccine for COVID-19? And if there is, what measures are we adopting as a nation to make sure that this gets to us? And, just generally, what are we doing to make sure that this comes to Nigeria and, helps reduce the pandemic, the scourge of the pandemic?
Yeah, thanks. So very briefly, we're all looking forward to an effective, safe, and affordable vaccine. So those are the three key words in this. There are many vaccine candidates at the moment. There are some that are closer to the end of phase 3 trials. One has just announced, but there are a few other announcements that will come in the next few weeks. We don't have all the details yet because the announcement was made through a press release and the actual data hasn't been shared, neither has a peer review publication been shared. So we don't know the details yet, but there is hope on the horizon, and that hope is very important for everyone working on this. And it also signals that at least one of the other vaccines in development will hopefully show its efficacy and safety. There are many other things that will determine what direction to go. One is the logistics required. The current Pfizer vaccine will require storage at -70, -80 degree temperatures, which is very challenging for us, especially in our environment. So we'll have to see which vaccine will go down with. To say that our engagement as a country in terms of what vaccine we will access will depend on a coalition called COVAX. COVAX is led by WHO and CEPI and Gavi. And what they have done is bring countries together to pool resources and pool risk. So rather than every country negotiating with every company with all the uncertainties around which vaccine will work and what they will cost, we have come together and formed this coalition led by WHO, which guarantees 20% of our population at least access to those vaccines. So it's an important first step. Of course, it doesn't cover the entire needs of the country, but at least we are sure that we will have sufficient access to one of the leading candidates as defined by us once one of them shows that it has the features, both in terms of efficacy, safety, and affordability that we need to provide to Nigerian population.
Thank you so much. Thank you so much, Dr. Chikwe. I'm going to sorry about that. I'm just going to, move right back to Professor Kevin Chika Urama. During your presentation, sir, you were talking about, there was a part of your presentation that really struck me, and that was integration. You mentioned that in the quest, to solve the issues in the health sector, we need to understand that there are different sectors involved. So we would like to know how do you propose that we involve these other sectors? Like, how do we restructure the organization of various other sectors, our social determinants, that need to play key players in healthcare? How do we come together? I don't know if you're getting my question, about the integration of everything. How do we do that?
Yeah, I think that's why in one of the policy recommendations we suggest that there needs to be a national conference on One Health for Nigeria. And then that national conference, we should have a singular objective of coming up with a Marshall Plan for One Health in Nigeria, which will include a number of all these other issues we're talking about. Intersectoral coordination and collaboration should be a key one in it. And I have to say, Nigeria is a shining light with regard to this kind of collaboration and coordination. And we have demonstrated it in the fight against Ebola, polio, and so many other things that Nigeria has really done very well in. So Nigeria could lead the way in having that Marshall Plan so that Africa can learn from it, because we're also pushing for that to be done at the African level. Always, the first part of bringing collaboration is to start a conversation. And that national conference could start that conversation in that direction. And we bring then not only health experts, but bring experts from the different sectors to look at how COVID-19 has really impacted on all the other sectors. And once we get finance ministers to understand that health is wealth, which not just by saying it, but by knowing the impacts, modeling the impacts of a healthy population on the economy, then it's easier to get them to even put the 15% we're asking for. So for me, the first step would be to organize that national conference.
Okay. Thank you so much, sir. Thank you. I'm going to be directing my next question to Dr. Hadiza before we engage some of our participants. Dr. Hadiza, are you there? So you mentioned during your presentation, there's a part that also stock, and that has to do with strategic health information systems. You talked a lot about digital health, right? So we want to know how do you think Nigeria is faring so far when it comes to adoption of digital healthcare, and what are the things that we do? What do you think the National Assembly, the House of Representatives, can do to help us adopt digital health technology into fighting epidemics and the health sector, strengthening the health systems in general?
So I think I'm happy the DJ is here. They've really, really worked very hard to make sure that they have, dashboards, both on their websites as well as in emergency operation centers across the country. Each state has an EOC. where basically data is mined, it's analyzed, it is discussed. So it's really a clear indication that we are now using data for decision making. For the first time, we can see that happening across the entire country. So this is a huge accomplishment. And I think this is something that we can begin to drive forward and say, how do we now leverage on these platforms to include other disease entities? And this is where integration comes in. We can't just set up platforms for just COVID-19. We need to begin to integrate other disease control programs. And so that these platforms can actually serve the whole of health, whether it is communicable diseases or non-communicable diseases. At a click of a button, you can have information. This information needs to be available to everybody so that everybody at all levels can use data. The fact that information is available to just a small group of persons that are called TWG members or core team or whatever, is not good enough. This information needs to be available for healthcare providers at all levels. Wherever you are situated, you must have access to information and data. And the more information we're able to put out there, the better equipped healthcare workers are to be able to provide care. But we also need informed citizens, informed clients that can actually sit down and understand their situation. There's a lot of myths and misconceptions, a lot of misinformation out there, a lot of conspiracy theories. The more we're able to override that and erase the misconceptions, the better for us. If in this climate, you can see the apathy that is already existing. In this particular climate, if we try to roll out vaccines, you can imagine the difficulty we're going to have. How many people are going to accept it and uptake it? So we really need to improve on information sharing at all levels, and mobile applications. Now, phone penetration is very, very high in Nigeria. A lot of people have smartphones, and it's very easy at a click of a button to get information. For those who do not have smartphones, radio is very common, particularly in our rural communities. We must, Ministry of Health must take charge, and provide the leadership to package the information that needs to be put out here. But collaboration with Ministry of Information is very critical, because if you say that for everything you do, you have to put money on the table, then it becomes a problem. Is there a way to collaborate, for health to collaborate with Ministry of Information, for the policy environment to be right for that collaboration to take place, so that we don't have to be spending humongous amounts of money to put information out there in the public? So I feel that there's a lot we can do, both using technology, but also using the structures that we have in our community. We have
already.
Yes.
Thank you so much. Yeah, thank you so much. I mean, I have to say I quite agree with what you say, because it means we already have existing structures, and in as much as we are seeing a lot of development in our world, doesn't mean we should just, ditch everything we've always had and embrace, technology. Yeah, we can embrace technology while still maximizing the systems we have in place. Thank you so much for that. We're going to have a quick question from Dr. Dan Gadzama. He's an executive member of the Association of Public Health Physicians of Nigeria. I don't know if he's available, so we can just promote him to the status of a panelist. So he can just come up and ask his question. Over to you, sir. Okay, I don't know if he's available. Dr. Dan Gadzama, is he available? Okay.
Yeah, good afternoon.
So if he's, okay, he's here. Yeah, good afternoon.
Yeah, thank you very much for having me. Yeah, so my question is to the amiable DG, NCDC. Yeah, we've noticed so many of the policies regarding particularly the use of face masks, even the FESIC reopening of markets, schools, and all that, that has happened across the country. It's been going on, and we see the trend seems to be following the Western countries. So I'm wondering if we have actually done any research locally, the operational research, to ascertain whether those things are actually applicable, or whether they are based on our own findings in Nigeria, or are we just copying the Western epidemiological trend? Thank you. That's the question I want if the DG can answer that.
Yeah, thank you for that one.
Okay, so thanks for that. I think the basic concept around that is we at NCDC believe in the universality of science. We don't believe that there's a science for the West, a science for the East, or a science for Nigeria. We believe in the universality of science. It is what has driven medicine. Paracetamol works in the West as it works in Nigeria. So once there's evidence of efficacy of either preventive or curative or treatment, we, of course, will try it out in our population. But once there's sufficient evidence, we implement. And that's how we have derived the evidence that we have used across the response. The evidence that has shown the use of therapeutics like dexamethasone, the evidence that has validity of the use of masks have come from different parts of the world. They haven't come from a single source. That is collated, synthesized by global organizations such as WHO, and we adapt these guidelines to our own context. So that's the first answer. But however, to throw that question back to you, sir, really, this is really what we expect our academic institutions in Nigeria to be doing, to lead on the research. Our role at NCDC, I showed our mandate at the beginning, is to synthesize science and use it to inform policy. Our primary responsibility at NCDC is not to do primary research on risk factors or control factors. Those are for yourselves, the scientists. Ours is to synthesize that. If you demonstrate that face masks don't work in our own context, we will include that in the evidence that we use for decision making at the national level. So we need to work closer together from the development of science, interpretation of science, and the use of science to drive policy and response.
Thank you so much for that, sir. I'm going to ask one final question, since you're already here, before I ask Dr. John Adedayo a question. So people want to know, are there any plans to integrate COVID-19 case management with routine health care services in Nigeria?
Oh, definitely. That's been the direction of travel, not just the management, but even the diagnostics. So we are moving away from having teams going around testing people to really supporting our centers, especially tertiary, and then we'll move to secondary, to be able to collect and do these tests themselves. With the new opportunities coming up, that should be straightforward. And then in terms of management, I think what COVID has done for our healthcare sector altogether is focus us on health, firstly, health worker safety in terms of work. So the use of PPEs, infection prevention and control equipment, the guidance should not be part of an outbreak response. Infection prevention and control should be part of our routine healthcare practice. And every hospital, as they're procuring medicines, they have to procure PPEs for their staff. And really, I would advocate that medical, NMA, the nurses, everyone should be at the forefront of advocating for this to be included in routine. So we at NCDC don't want to be distributing PPEs. we want this to be included in the routine procurement practices of everybody running a hospital, public or private. And that way we will normalize the use of these things. We want every patient to insist that doctors need to be appropriately protected for themselves and for their patients. So if a doctor is approaching you without gloves to examine you, as a patient, he must be empowered to say no, that the right thing is to use gloves. So these are things, it includes education, patient education, doctor education, and also education of the leaders of our healthcare facilities to do appropriate procurement at the beginning of the year so that they have these things in stock and don't wait for it to be supplied as part of an outbreak response.
Wow, thank you so much, sir. This reaffirms what Dr. Walter said earlier today in the earlier session. He said a lot of capital expenditure is going, recurrent expenditure is going into payment of salaries. We need to have more of that focused, channel towards training of healthcare workers and education. Thank you so much. At this point, I'm going to hand over to Obinna to, handle the rest of the session. Thank you. It's been a very enlightening session, and I am still here to learn and interact with all of you. Thanks.
Thank you, Chioma. I must say this has been very enlightening, and this has generated a lot of feedback for the House of Representatives. In concluding, I want to gain for the benefit of the attendees, the participants, the idea behind this session, which these roundtable sessions of the House of Reps, especially championed by the Committee on Media and Public Affairs of the House, is to generate an ongoing channel of communication between the relevant committees of each sector and the stakeholders of that, the critical stakeholders of that sector. So we appreciate the participation of the House committees on health services and health institutions. We'll be continuing tomorrow. We also appreciate the attendance of everybody who has contributed from the first session, Dr. Walter Kazadi Mulumbo, who's the country representatives of WHO to Nigeria, Dr. Ibrahim Wada of NISA Premier, Dr. Gafar Alawode, and the Minister of Health and the DG of the Budget Office of the Federation. We also want to appreciate the participation of Dr. Chikwe Ihekweazu, the DG of NCDC. He has provided a lot of information and feedback that will be valuable for future engagements. We also thank the representatives from UNICEF, representing Dr. Sanjana Bhardwaj. Thank you for your contribution. We also want to acknowledge Dr. Hadiza Khamofu, the Country Director of FHI 360. Thank you for your contribution. Professor Kevin Chika Urama, Senior Director of Africa Development Institution. Thank you for your contributions. And Dr. John Adedayo of MSH, thank you for your contributions. I must mention that all presentations will be made available on the websites for access to for the participants at this event. And before we end, I need to really give special thanks to Dr. Nkem, the moderator of these sessions. I'm sure a lot of the people on the panel know her, but for the benefit of those who may not know as attendees, she has over 25 years of experience in health program evaluation, service delivery assessments, M&E, accountability mechanisms, health policy analysis, program costing, the whole works of health, of the health sector. She has consulted, she continues to consult for UN agencies, including WHO and the World Bank, as well as Bill and Melinda Gates Foundation, DFID, among others. She's currently a fellow of the Royal Society of Public Health UK. And she heads Preston. Preston is a development foundation, has expanded health beyond Nigeria, continues to represent healthcare in Nigeria, on the international stage. So I really want to thank her for gracing this occasion and supporting us with her moderation. I also want to thank Dr. Chioma Nwakanma for assisting too. And as we wrap up this session, I would like to announce that tomorrow we'll be considering very exciting, very important conversations. We'll be looking at capital flight and brain drain in the health sector. We have the participation of the Minister of State for Health, Honorable Dr. Adedayo. We also have the President of NMA, Professor Innocent Uja. He'll be joining us. The MDC of Cedar Crest, Dr. Felix Ogedebe, and then Dr. Ola Rekunri will also be joining us to discuss that very important subject. We also have Bilkis Mohammed. She was the immediate past Secretary General of Nigerian Association of Registered Doctors. She'll be lending her voice to that conversation. We'll also have the final session, which will consider health insurance and tax-based financing. Very important. In fact, it was touched upon in the previous conversation. It's going to have, including the Executive Director of NHIS and a lot of other resourceful persons on the panel. So as we end, I want to say a very big thank you to everybody who has participated today. I'll hand over to the moderator to conclude the session. Thank you.
Thank you, Obina. I think you've covered all the bases. I just want to close by saying, if you haven't already taken your COVID-19 test, because you don't have symptoms, please go out and do the test. Hadiza has put the call out that we need to do more testing. So just avail yourself. So thank you very much, panelists, for your wealth of experience and the contributions you've made. We've all learned a lot. Thank you, participants, for hanging in there and remaining engaged. So we look forward to having you join sessions 3 and 4 tomorrow. And you all have a good evening. Thank you.